So frontline therapy in CLL also is complicated. It's actually probably gotten more complicated lately with the results of the Amplify trial reading out at the end of 2024 and getting published this year. I think the first thing I'll say is I do still think that there's a role for sending prognostic tests. I mean, I think the nihilist would say, well, if you're going to treat someone with your favorite regimen, regardless of the test, maybe you don't need to test. Well, I still do test. And so here's the reason. We know that patients with favorable risk disease have truly excellent outcomes with any therapy that they get. And so my view is those are the patients that I would strongly encourage to do a time-limited regimen because time-limited regimens really have a lot of advantages, especially for the patients who are going to have excellent responses. So first of all, cost is less when you're not on something indefinitely. Two, toxicity is less. Once you're off something in general, there are no prolonged toxicities. And so for my patients with favorable risk disease, meaning no TP53 aberration, no 17p, and mutated IgHV, I steer those patients toward a time-limited regimen. And I'd been doing mostly venetoclax obinutuzumab. However, now I'm actually quite open to the combination of acalabrutinib with venetoclax for the patients of mine that have favorable risk disease but are seeking an all-oral option. The next group of patients is the less favorable patients. So I think that's a bit more nuanced. I think it kind of depends on what the patient's goals are. I don't think it's wrong to do time limited in someone with less favorable risk disease. You just have to have an understanding that the remissions are likely going to be shorter as compared to the patients with the favorable markers. But they still have the potential for retreatment. They still have all the other benefits of time limited. It's just the duration of the time from which they have first line until when they need their second therapy is going to be shorter. So unmutated IgHV in general, I think they're well served by Veno, but the PFS is going to be a little shorter than the mutated counterparts. I think AV may not work quite as well in the unmutated patients, but if someone's super young and very motivated to get a deep remission, I think AVO might be reasonable for a select group of patients for the time-limited options. And of course, the use of a continuous BTK inhibitor, totally reasonable for the unmutated patients. Now, patients with 17p deletion, TP53 mutation, we tend to think that the longest remissions are going to be with the use of a continuous BTK inhibitor. However, if the patient has a strong preference for time limit, I'm still open to that discussion. But the data are a bit more scarce given that those patients weren't included in a lot of our studies. One example is that they were completely excluded from the Amplify study, but there is a phase 2 led by Dr. McDavids that did actually enrich the trial population for patients with TP53 aberrations. And so there is some experience with AVO as one example for that highest risk subgroup.